All right, guys, we're going to get started. Thank you for your patience. We are hoping to live stream to Tenant. We're just going to see how it goes. Okay. Welcome everyone. Thank you so much for coming to this Renal Education Morning. Just going to do a quick acknowledgement of country. Just like to acknowledge the Aranda people, the traditional custodians of this land in which we meet. I'd like to pay my respects to elders past, present and future. We've got Rebecca Gilmour from Alice Springs Hospital. She's a renal educator and she's going to give her talk on all things renal disease in Central Australia.
Okay. Well, thank you all for the opportunity to talk today. My name is Beck Gilmour. I need to acknowledge a few of my colleagues who've helped me put the statistics together for this presentation. So I'd like to acknowledge Stacey, Femal, Cynthia, Emil Tabata and Hayley Connolly, who are on our chronic kidney disease team. And like I said, they've given me a little bit of numbers, because the numbers are very fluid with kidney disease. So today I'm going to give a bit of an overview of renal disease in general, renal disease in the Northern Territory, and then specifically our hemodialysis population, because it's by far our primary renal replacement therapy that we use in the Territory. I can talk underwater, so please, if you have any questions, just stop me. Once I get on a roll, I'll be hard to interrupt. So pop a hand up if you'd like to ask any questions. Happy to take questions all the way through at any point. Learning objectives for today will describe the different stages of CKD and identify the primary causes of renal disease in the Territory and in Australia more broadly. Discuss the incidence of CKD5 in Central Australia. Have a look at the modality options for CKD5 patients. Have a little look at some special, I say nursing management elements, but really health management overview elements for the renal clients. Identify clinical and psychosocial impact of missed dialysis treatments. And I believe we have a case study afterwards on missed dialysis and some of the complications. So mine will just be a very quick overview of what we hit there. And then a couple of key messages to increase community awareness regarding renal risk strategies and promoting consistent messages to the general public about renal disease and primary prevention strategies that we're working on. So a little bit about me. If you're going to listen to me for an hour, you need to know that I know what I'm talking about. Yeah, destined to be a nurse from a very young age. It's me at 2. But I've been in Central Australia since 2000 and I've been working with the renal service since 2001. So 20 years of experience with our demographic. I've actually worked in all the different roles in renal disease too. So I've been a PD nurse, an access nurse, a hemodialysis coordinator, and currently I'm the clinical nurse educator for the ward up in the hospital and the acute dialysis setting, which is where we look after all those really complex clients who've missed treatments. So about renal disease, there are 2 types. Yeah, you have acute kidney disease and you have chronic kidney disease. Acute has a sudden onset and is potentially reversible, and chronic renal disease has a slow insidious onset and is irreversible. You can also get acute on chronic renal disease. So that's where you have a pre-existing condition that means your kidney function's deteriorating. You have an infection or something that reduces your kidney function for a short period of time, and then we treat that infection and the function comes back, but it doesn't come back up to where it should. It just comes back up to where it was, hopefully, before the infection hit. So how do we work out how kidneys function? Basic anatomy, in your kidney. You have what we call a glomerulus. Took me ages to pronounce that word. Then I heard the head of nephrology call it a glom, so I've called it a glom ever since. So the glom is where the filtration's done in the kidneys, and that's where we clean the blood, basically. And when we measure kidney function, we tend to use creatinine, and that's because it's freely filtered. So a lot of substances are reabsorbed or secreted in the renal tubules after the glomerulus in the filtering unit. Creatinine is not so much, so it's our best marker of how well the kidneys are working. There are several formulas that are around, scientific methods for working out what a person's GFR is. We use the CKD EPI formula because it's been validated for different racial groups, whereas the older formulas, MDRD and Hockrott and Golf and things that were available before this one, weren't as valid for our Indigenous population and didn't give us as accurate a marking of what kidney function was doing. So that was developed in 2009 by the CKD epidemiology collaboration. So we got 5 stages of kidney disease. Yeah. Stage 1 is a GFR of greater than 90, and that's normal or increased GFR with no other evidence of kidney damage. These people generally have no idea that they have any sort of kidney issue because they're not symptomatic at all. Might have a bit of protein in the urine, but they're still cleaning their blood quite efficiently. It's just that, you know, there's something in the urine that shouldn't be there, really. Stage 2 is a GFR of 60 to 90, and that's a slight decrease in GFR with other evidence of kidney damage. Again, most people with eGFRs of 60 to 90 aren't aware that they've got an issue. If you're diabetic, we'll start testing your GFR pretty regularly because it's one of the complications that comes from being diabetic. So that's where we catch stage 2 people, is if we see a slight deterioration. You can actually lose up to 95% of your kidney function without needing any renal replacement therapy to survive. And dialysis only replaces that 5%, which is why people can do live kidney donations and things like that. So then we get into stages 3A and 3B, which is a moderate decrease in GFR without other evidence of kidney damage. We used to just chunk that all together and call it stage 3, but there's such a big difference between 30 and 60 that the National Kidney Foundation broke it into A and B, I think just a year or 2 ago. It's very recent. Stage 4 is an eGFR of 15 to 29, and this is where the renal service and the hospital and the acute setting really get involved with the renal patients. If you're up in 3A, you generally tend to be managed by primary health organisations like Congress, or Purple House does a lot of work with people too. But when you're in stage 4, you've got a severe decrease in your GFR with or without other evidence of kidney damage, and you're starting to feel it, and there's starting to be physical implications towards that. When people hit an eGFR of 20, we like to create an AV fistula, because generally speaking, they've got about 6 months before they're going to progress to stage 5, and it takes 6 weeks for a fistula to mature. So we'd like our fistula to be ready to go for the first dialysis session, because clinical evidence has showed that just about doubles your prognosis on dialysis. Yeah, so we like getting fistulas into people early on. It's very hard to get someone with a GFR of 20 to see the need to have a fistula though. So we get a lot of what we call DNAs, or did not arrives, for those appointments. But we've got very good rates on how many people dialyse using fistulas. Oops. And then an eGFR of under 15, National Kidney Foundation classes as a stage 5 chronic kidney disease or needing renal replacement therapy to survive. Does anyone know when you commence someone on dialysis? I like to involve the group. Sorry, I'll ask you random questions all the way through. Yeah. It's when they become symptomatic. Yeah, so you're trying to slow the progression as much as you can and only start dialysis when you absolutely need to. So in our Western European demographic, a lot of people get symptomatic at around 15. Yeah, our Indigenous population's really resilient though, and what we find is our patients we're 95% Indigenous patients in our renal service, and they don't tend to become symptomatic till eGFRs of about 5 or 6. So what happens is we have this grey area, yeah, where people might be in stage 5 but haven't yet commenced. And that's one of the treatment goals. It's good management that we keep them off till they're 5 or 6. But yeah, once they hit down here, they can't maintain homeostasis and they need dialysis to survive. Numbers. It's a lovely picture of the Todd River flowing. Yeah. The water coming in. See the beer cans down the bottom. Got a bit of floating lemonade bottle and rubbish. Unfortunately, it's a bit of a drain. You can't find pictures without that sort of thing in it. So this is the incidence of renal disease per million head of population. If you compare the Northern Territory to the other states around the country, you can see they have about 100 patients per million people. We have about 500 patients per million people. And this incidence just keeps climbing. Yeah, we're identifying people with kidney disease earlier, and people are living longer on the machine because we're doing a good job. We end up with this cascade of patients coming through. So that's taken from 2006 ANZ data, which is the national body for collecting stats on chronic kidney disease. It's always a few years behind because it takes a few years to process and to approve the information. But yeah, huge disease. We actually have the highest rates anywhere in the world for CKD5. So on hemodialysis, which is by far our most popular treatment choice, we have 386 patients that are on our books in the centre, but our catchment area is as big as New South Wales. So we cross 3 borders and go halfway up the NT as well. Of those 386 patients, 7 patients do home hemodialysis through the Northern Territory Government, which is where they train themselves. They get demountable in their community, in what we call hotspot communities. In other places, home dialysis is carried out in people's homes, but we have issues with overcrowding and with power supply and that sort of thing. So NCG felt that the best way to provide home dialysis services was to look for communities that had several people in it, put in a demountable that those people would have keys to, and then they can access that space to do their own dialysis. So we have 1 patient in Ali Kurung, 3 at Amugana, 2 at Lake Nash, and 1 at Tea Tree. Very, very difficult to train. It takes 6 weeks to train a registered nurse to perform hemodialysis in Alice. A lot of our clients have an education level of about Year 9, Year 10, literacy and numeracy challenges, as well as a different health perception. It's not that we can't train people to do dialysis, but it takes a lot longer and it's really resource intensive. Stages 1 to 5, and if there's 873 people, that's not including the 386 who are on dialysis. These are people in the wings waiting and progressing through their kidney disease. So we'll lose a lot of them before they make it to stage 5 through cardiovascular events, sadly. So they won't all get on dialysis, but there are 353 patients in stages 1 and 2 we've identified, 180 in stage 3. Sorry, that's 3A, 172 in 3B, 122 in stage 4, so we'd expect to see them coming onto the books in the next sort of 12 to 24 months. And then 46 in stage 5 who are in that grey area that haven't actually become symptomatic yet. So it can be a bit scary looking into the future. We've seen projections and I guess capacity in the territory blow out. Like I say, I've been here 20 years. So when I first arrived, we just had the Flynn Drive Dialysis Centre, which had 26 chairs. Numbers soon were too big to accommodate that centre, so we sent a lot of patients back to Barclay when we created the Tennant Creek unit, and then that unit's been expanded since. Blown out over capacity again and put the 8-chair unit in the hospital. Blown out over capacity again, and Gap Road Nephro Centre went in. But each time this happens, there's a lot of cost associated with providing satellite dialysis to people. So we're always a little bit under when we project how many patients we're going to end up with, and the numbers tend to be a bit higher. So that's how we get caught out in that area. So what causes it? This is a little bit fluid too, but as you can see, our primary cause here is diabetic nephropathy. It's number 1 biggest cause of renal disease. When I started in 2000, it wasn't the case. Glomerulonephritis was number 1. So that comes post-streptococcal A infection. Your body lays down IgA antibodies in the glomerulus, and then it kind of clogs up the filtering unit and damages it. That comes post-strep throat, or often infected scabies that are untreated for a long period of time can lead to that as well. Lots of other causes, but they make up very, very small percentages of our patient catchment. We're primarily diabetic nephropathy and glomerulonephritis here.
Is that because we've gotten on top of treating strep A, so it's less, renal diabetes increased?
It's on par with the national trend and increase in diabetes, yeah. And it's not just us, you see that trend and increase in diabetes leading they kind of run in conjunction with each other. So there's this increase in diabetes incidence and a corresponding increase in renal disease incidence, unfortunately.
Can you just talk about
Reflux
reflux?
nephropathy. Again, that's where you have issues where your kidneys don't filter properly and you have your filtrate coming back up into the renal tubules and impairing the flow of urine coming out. Tends to be a bit more genetic rather than a lifestyle-acquired disease that leads to renal disease.
So it's reflux within the kidney itself, not reflux as in you have
Not reflux as in you have reflux, but reflux as in there's one direction your urine should travel in,
Yep.
yeah, and it should go down those renal tubules into your bladder and then out. If there's a problem, then it kind of banks up in the glomerulus and it can't filter properly. Yeah. It's interesting to note that the third leading cause is hypertension. It's the same sort of deal. Kidneys work under a specific pressure. So if you've got high blood pressure, go and treat it. You don't want to end up on dialysis. Yeah. Keep it under 130 on 90 and you'll be okay. But once it starts getting up over that, we end up with problems. One of the biggest innovations in preventing renal disease and slowing the progression has been ACE inhibitors, because we find they're both renovascular and cardiovascular protective. Cardiovascular disease takes out a lot of our patients, like we were saying, before they even make it to end stage. But what it does is your glom, that filtering unit, has a blood feeding in, blood feeding out. Yeah, so the afferent arteriole, where the blood feeds out, it dilates the afferent arteriole and reduces the pressure within the whole glomerulus, and that's how it preserves residual renal function. So like I say, historically, glomerulonephritis was number one, but diabetic nephropathy took it over in 2004. They were pretty even rates up until then, 26 to 27% of clients. But yeah, diabetes has been number one ever since. So what's that mean for us in Alice? If you're a nurse or if you're a health professional, it means it doesn't matter where you work, you're going to come across renal patients. And redeployment, ward overflow, and the sheer amount of clients that are running around with kidney disease mean that you're going to come in contact with them at some point. So it's essential that we know what's specific for them and what's different and how we can care for them best. So when you're in stage 5, it's really not a nice disease to end up with. They say it's the most lifestyle impacting disease, or it affects the quality of life more than any other condition you can have. So you have 4 choices if you end up with CKD once you're in stage 5. You can have peritoneal dialysis, which is like it's a self-managed therapy. It's on your renal pathway, it's the treatment of choice to commence on. Yeah, because it preserves residual renal function, which impacts on how long you're going to survive on dialysis. It works 24/7 because you've always got to dwell in your abdomen, so you're always dialysing. Kidneys work 24/7 too. Hemodialysis, you're playing a lot of catch-up because you're only dialysing 3 times a week for 5 hours a time. So you get all these peaks and troughs in your biochemistry. Peritoneal dialysis, it's a little bit gentler. Your fluid and your diet restrictions aren't as strenuous either, and you manage your own therapy at home. But your biggest risk is peritonitis. Yeah, and our environmental health here means that it's often not suitable for our clients. All clients have these 4 options explained to them though, and again, when you look at clinical evidence, people who pick their own therapy are far more likely to engage and adhere to the therapy recommendations than someone who's told you have to do this therapy. So people are allowed to choose the modality option that suits them. There's transplantation, cost effective, the least lifestyle impairing treatment option, but still a lifelong treatment option. So you have to take immunosuppressives for the rest of your life if you're on it. And again, in our patient demographic, if you think about that incidence slide with Indigenous people, what we've found in the past is when we've transplanted from younger siblings or relatives, that sibling or relative later on develops renal disease. Yeah, it's a really strong genetic factor as well. So pretty much it's Godiva donations for our clients, and that's the choices that they have. 3 to 4 year wait for a Godiva kidney, Yeah, if you haven't seen all the Donate Life stuff out there, please get out. If you want to be a donor, we need far more kidneys out there for people. You can palliate. Decide I don't want to be transplanted, I don't want to have PD, and I don't want to go on that hemo, it's terrible. Kerry Packer palliated. He's our famous renal client that we had. Richest man in the country, got a transplant, and it rejected about, I think, 6 months after, and he chose to palliate instead. And then there's hemodialysis. We call it club hemo, by far the treatment of choice, yeah? So you just come in, stick your arm out, someone does it all for you, get a sandwich, go home on the bus, it's great fun. So 3 options there. You can have home hemodialysis if you're pretty savvy and you can work that machine yourself, but you need a support worker who's going to be around just in case you lose consciousness on the machine so they can troubleshoot. Satellite dialysis, so this is where most of our patients dialyse. Again, most expensive way to provide dialysis treatment. But Flynn Drive, Gap Road, KDU in the hospital setting, and Tennant Creek Dialysis Unit are all examples of satellite units. We have a unit at Katherine as well, but it's kind of top-end based. In 2000, when I started working for the renal service, the Flynn Drive Dialysis Unit with 26 chairs was the biggest satellite unit in the Southern Hemisphere. Yeah. It's been taken out by another unit in Sydney since, but Nephrocare has now increased to 32 chairs. My apologies, I need to update that slide. Tennant Creek has 17 chairs, and the Western Desert Dialysis Service, I'm sure you guys have heard of Purple House, yeah, 32 chairs, all spread throughout the territory. They're a fantastic service. They get people home on dialysis, not permanently like a home treatment, but as a respite service for 2 or 3 months so that they can see family. Like I say, our catchment area is as big as New South Wales. So I often, people get really annoyed at patients that don't show up or, don't adhere to treatment on occasion. But I often think if you want to have an analogy that's about even for what our clients are going through, if you imagine you go to the doctor tomorrow and he tells you have some condition that you don't understand, flies you to China and drops you in the middle of China where no one speaks English and you're away from all your key support networks and your family, and then you give an acupuncture, you don't really kind of understand why. That's about where these clients are at. So it's not unreasonable to think that they might not show up or understand why they need to show up all the time.
How many chairs all up in Alice?
20, 40, 46. Yeah, Nephrocare's Gap Road, so that's 46, and there's another 3 at Purple House. 49. Oh, and 8 at KDU as well. Yeah, so 50 something. 8 at KDU, and we can actually dialyse in the ICU as well. We have 2 machines, but 5 bays that you can do really dialysis on people who are really sick. So yeah, like I said, that catchment area is as big as New South Wales, and there are capacity issues if people miss dialysis. So when we had a bit more space and fewer clients, what would happen is you'd sort of go, oh, you can't come today, that's all right, we'll make your booking for tomorrow. Now tomorrow's list is so booked out that you can't accommodate people like that. So people do have to come when their dialysis is I guess, offered. And if they don't show up, there's serious complications that occur with that. Oh, there we go. Look, I'm reading on. Serious complications with mistreatments once patients present for acute hemodialysis. This is where you have your really tricky treatments. Yeah, that's why I love working in the hospital, because you get to design really complex dialysis sessions for people. The big potential complication that we want to avoid at all costs is called dialysis disequilibrium syndrome, and that's like I was saying, you have all these peaks and troughs in biochemistry, and when you dialyse someone, you rip them back into normal range. Yeah. If someone misses dialysis, though, the biochemistry just keeps climbing, and it's when you rip someone from really, really high levels of urea and creatinine back into normal range that you end up with this complication. basically you're trying to change the biodynamics too quickly, and what happens is fluid moves into the fluid crosses the brain barrier and tries to dilute the really uremic when you're dialysing the highly uremic blood. So what that results in is coma and death on the machine, and it's really important that we avoid DDS. We have a couple of policies and procedures in place that help us avoid that, but that's why it's so serious when people miss treatments. And a lot of our clients don't really understand how serious it can be and the risk that they're putting themselves at. A lot of people think hyperkalemia is the biggest risk, which will cause arrhythmias and knock your patient off very quickly. But when you actually bring them into hospital and start initiating dialysis again, it's very dicey and you need to go gentle. Left ventricular hypertrophy is another complication. So this is associated with big fluid loads and having too much fluid running around your body. Kidneys are responsible for fluid balance, and if they don't function anymore, basically, not all clients, but about 80% of them, what goes in stays in because they can't void. So there's only so many places that fluid can go, and what eventually happens, the first place it goes is the cardiovascular system. That takes as much fluid as it can possibly take, and then fluid starts leaking out into your edematous spaces. So in left ventricular hypertrophy, the heart has a lot of trouble pumping that extra fluid around the body, and what happens is it eventually it stretches, and the left ventricle becomes like this big floppy heart that won't contract properly, and that causes issues with blood pressure and eventually will cause cardiac complications too. Cramping and hypertension are the most common complications on the machine, because we're often going for really big fluid loads on our clients because they tend to not adhere to their fluid restrictions. You can't take more than 1 litre an hour out of anyone, and you've got a five-hour treatment. And if you're taking 1 litre an hour out of someone on the machine, the potential for complications is huge. We'd far rather take less than 800 mils in every session. But you can't leave the fluid in there either, or you end up with these left ventricular hypertrophy and things over time. It's a bit of a balance trying to prevent complications. So wagging, as I like to call it, is common, or non-attendance is quite common in our demographic. But it should never lead to complacency, and you guys would be picking them up, I imagine, when they're really unwell. So bringing them into us. So we know that these are issues. We're not fond of the rotating door either. And you do have certain clients that are just rotating door clients that come back. And if you drive ambulances, you'll even have names in your head. I know this one and I know that one, and I know, of people who just do this continually. It can be a real issue for people, and it is very frustrating. Why don't they come? Why don't they, basically, they don't pull out of dialysis because they don't want to die, because that's what happens if you withdraw. But they do have great difficulty adhering to this really complex treatment regime.
Off the top of your head, do you have any idea around the stats around disequilibrium syndrome, how often that actually leads to death, or coma and death, you said before?
Yeah.
Because we often see it, and we often, we'll see it maybe in just acute confusion and things like that, and we'll say, it's disequilibrium syndrome, they've been missed and they've had a big one come off.
There are levels to it. So, and actually I'll go into it in a while, but we have some really good policies set up in order to prevent it. So that's your missed dialysis protocol. If someone's missed more than 3 sessions, they're not allowed to be dialysed in the satellite units. They have to come to the hospital and be dialysed there, and they can't have a normal dialysis treatment. So what you do is you start off very gentle. You give them a 2-hour treatment with very low pump speeds, very small dialyzer, and reduce, we talk in terms of clearance. So in a standard session, you're trying to reduce the person's blood urea by 70%, and we call it a urea reduction ratio. In a missed dialysis session, you're trying to keep the URR under 30%. So it's really, really gentle, really short session to bring that biochemistry down a little bit, and then a follow-up session the next day that's normal to bring them back. So we stagger them down in order to try and prevent this. The problem is everyone has different residual renal function, And no, not everyone sticks to their fluid and dietary restrictions. So how much, I use lay terms a lot. Sorry, I've been teaching across language barriers for quite some time. But too much junk in the blood, yeah. People have different levels of rubbish in their blood, yeah, depending on residual renal function and what they're consuming and things.
Is everyone's limit, like their fluid intake limit different?
No, it's pretty standard across the board. It does vary because it should be like 10 to 15% of your total body weight, but you can have general recommendations. So we say 800 mils a day is standard for a renal client. If they're very unwell or extremely overloaded, we'll restrict that further to 500 mils. So if you try and think about, see that coffee cup on the table over there? That's 2 of those cups in a day. Could you stick to that? And not drink any more than that in 40-degree heat, especially if you're not sticking with your salt restriction, yeah, because water follows salt. So it's a hard thing for anyone to do, and in all dialysis populations, it's a running joke. Yeah, I hate dialysis and stuff like this because I can't have any fluid. And it's not just liquid that you drink; it's actually a fluid component that's in your food as well. So there's a lot of things that sneak in that patients aren't quite aware of. Like you wouldn't think custard and ice cream and yogurt and things like that are fluids as well. And then there's foods that have high fluid content. So pasta is about 2/3 fluid. Rice, if you think about it, is about half fluid. Yeah, lots of places you can get hidden fluid that you don't actually realise you're consuming. So I'll talk a little bit about that psychosocial impact of missed dialysis. The health perception is very different from traditional Indigenous people, and we have the most traditional people anywhere in the country in central and top end of the Northern Territory. So you get a lot of this, I'm alright, you know me, until I can't physically get up, I'm going to be alright, The symptoms differ because they're dependent on residual renal function. And there are big issues with dislocation. That's how that Western Desert Service was born. If you ever read Heidi when you're a kid, I often think of that, which is a story of a girl from the Swiss Alps who goes to the town. She grows up on a farmland, with her grandfather and stuff, goes to the town and becomes really sick and no one can figure out why. And eventually they send her back up to the Alps. It turns out she's just homesick. You get a lot of that too. There's this cumulative effect of mixed HD rather than instant damage. So a lot of the health perception is, I've got a headache, I take a Panadol, it's better. My arm hurts, I've broken a bone, there's something wrong. Because it doesn't hurt you now. So we'll say, don't miss dialysis, you'll make yourself sick. They'll miss dialysis, come back a little bit heavy, a little bit breathless and go, you don't know what you're talking about, I'm fine. But it doesn't catch up with you today. It might mean that you live 5 years on the machine rather than 15 or 20. It catches up with you later on. And deferment, so our capacity issues add to that message. If we've got too many people to dialyse on a given day, not enough chairs to do it, we'll put as many people on as we can, and then the people who are left over will triage. So we'll take bloods on them. Whoever's got the highest potassium will be dialysed, and people who are still stable will be sent home and told to come back tomorrow. Yeah? That sends the message that it's okay to miss. Yeah. So, one of the first questions you ask a dialysis client should be, when was your last dialysis session? And some clients will fib. Yeah? Be aware of that one too. But it's the first thing we check on CareSys when they rock up to the hospital. Each episode's logged in. So why do we worry? There's a potential for complications that's increased with underdialysed patients. Once your urea's up, you get an increased potential for DDS, for cramping, for bleeding, for hypertension, for seizures, and all sorts of fun stuff like that. The big concerns are hyperkalemia and pulmonary edema. So, fluid goes to the lungs and people can't breathe because that's one of your spaces that fill up when you can't void. And hyperkalemia, high potassiums lead to arrhythmias that, can put you into cardiac arrest. So we have these missed dialysis protocols and new patient regimes, probably leading the country with those, because other places don't have these issues with patients wagging, or not, well, not to this extent that we see it. When dialysis nurses come from other states and meet our clients, they're flabbergasted. Like, what? How can you have 10 litres on a patient? I'm like, I've seen 23 litres on a patient. What are you about? Yeah. So, like I say, they're available on our policy centre if people want to do a bit more hunting. There's missed dialysis CARS procedure, and there's a new patient regime. The missed dialysis procedure guides nurses how to dialyse people if they've missed 3 or 4 sessions or more. And then the new patient protocol is a gentle introduction to dialysis, because usually people who are commencing are really uremic as well. And that's where you see that really, really high creatinines and urea levels. So when people start, it's a 9-day pathway. They have dialysis on days 1, 2 and 3. They have a day off. And then they have dialysis on days 5, 7 and 9. We start them off very, very gently. So they have a 2-hour treatment on day 1, 3-hour treatment on day 2, 4-hour treatment on day 3, day off, and then 4-hour treatments till the end of the week. By the time they're off that 9-day pathway, the nephrologists have enough information to be able to design a dialysis prescription for them. So talk about access. This is a group question. Have a think before I get to it. So when we talk about access in renal disease in CKD5, we're talking about how we access the blood in order to clean it. The AV fistula is the access of choice. Yeah, they last 5 to 7 years. They're associated with the best outcomes. We'd like everyone to dialyse through a fistula. If you're on HD, the AV graft is choice number 2. So this is for people who don't have suitable native blood vessels for a fistula creation. Grafts last 1 to 3 years on average. Yeah. And then your third option, which is your late presenter or someone you didn't realise needed dialysis, or someone who dodged their fistula creation appointment for a good year. They're the people who show up extremely uremic at the hospital presenting, and we have to dialyse them. They need central venous access so that we can get enough blood out and put it back. When you talk about IV drips and IV rates on the wards, 500 mils an hour is a pretty intense rate to administer something to someone.